blood is often treated as a label, a letter, or a color on a card, something quickly checked and just as quickly forgotten. But biologically, blood is an inherited constraint, passed down quietly through generations. Most of the time, it does its work without drawing attention. It circulates, delivers oxygen, and disappears into the background of daily life. For the majority of people, it never becomes a problem, until a specific situation forces a hidden detail to surface. Pregnancy is one of the rare moments when these invisible details collide. Two biological systems, each inherited from a different lineage, suddenly interact in ways that matter. For most of human history, people had no way to see this interaction, let alone understand it. Outcomes were observed, not explained. Patterns appeared, tragedies repeated, and no clear cause could be named. The Rh factor existed long before medicine could recognize it. Modern medicine did not create this problem, and it did not invent the risk. It learned how to see it. Once identified, this single blood detail reshaped how pregnancies were monitored and protected. Today, its presence is quietly checked, documented, and managed in hospitals around the world. If you or someone close to you has been pregnant, donated blood, or received a transfusion, this factor has already mattered, even if you never noticed it. For centuries, pregnancy complications were observed without clear explanations. Midwives and physicians noticed patterns that repeated across families and regions. Some newborns became severely ill shortly after birth, while others thrived under similar conditions. These outcomes were often attributed to fate, infection, or unknown maternal weakness. There was no framework to connect blood inheritance to these results. By the early 20th century, medicine began shifting from observation to classification. Blood was no longer seen only as a fluid, but as a system with internal differences. The discovery of the ABO blood groups helped explain certain transfusion reactions. Yet even with this progress, doctors continued to encounter newborn illnesses that did not fit existing models. Something remained unaccounted for. The problem became most visible in maternity wards. Some infants developed severe anemia, jaundice, or swelling without obvious cause. The pattern often appeared in families where earlier pregnancies had been uncomplicated. Physicians noticed that the risk increased with subsequent births, especially when parents had different blood characteristics. These observations suggested an interaction rather than a single inherited defect. The turning point came when researchers began studying immune reactions more closely. They realized that blood compatibility was not limited to ABO groups. Experiments showed that certain red blood cells triggered immune responses even when ABO types matched. This hinted at an additional marker on the surface of red blood cells. The Rh factor emerged from this line of investigation. The name itself came from laboratory work involving rhesus monkeys used to study immune reactions. While the naming was technical, the implications were human and immediate. Doctors finally had a way to describe a previously invisible difference between people. This distinction explained why some immune systems reacted strongly after exposure. It also clarified why timing mattered in pregnancy outcomes. What made the Rh factor difficult to detect was its silence. Most individuals with Rh-negative blood live their entire lives without symptoms. No illness, no warning signs, no daily limitation. The factor only becomes relevant when Rh-negative and Rh-positive blood interact in specific ways. Without modern testing, these moments passed unnoticed. Historically, this meant that causes were inferred only after harm occurred. A first pregnancy might appear normal, reinforcing the belief that no risk existed. Only later did complications arise, often without explanation. This delayed response made it harder to identify a consistent cause. The biological mechanism remained hidden behind time. The recognition of Rh incompatibility did not happen overnight. It required patterns across hospitals, regions, and decades to be compared. As medical record-keeping improved, similarities became harder to dismiss. Researchers could finally link newborn illness to maternal immune reactions. This marked a shift from mystery to mechanism. Once the Rh factor was identified, it reframed earlier observations. Events once labeled unpredictable gained biological context. Medicine moved closer to understanding how inherited traits could interact rather than act alone. This discovery did not solve every problem immediately, but it opened a path toward prevention that had never existed before. At a biological level, the Rh factor is a protein found on the surface of red blood cells. If this protein is present, the blood is classified as Rh positive. If it is absent, the blood is classified as Rh negative. This distinction exists independently of the ABO blood groups. It is a surface marker, not a blood type by itself. Its importance lies in how the immune system recognizes what belongs and what does not. The immune system is designed to identify foreign material and respond to it. Red blood cells usually circulate without interference because they are recognized as self. When cells carrying unfamiliar surface markers enter the bloodstream, the immune system may respond by producing antibodies. This reaction does not happen instantly. It requires exposure and recognition over time. In pregnancy, this exposure can occur when fetal blood cells enter the maternal bloodstream. This transfer is often minimal and unnoticed. During a first pregnancy, the mother's immune system may encounter Rh-positive cells for the first time. In most cases, the response is slow or incomplete. This is why initial pregnancies often appear unaffected. The process changes after sensitization. Once the immune system has learned to recognize the Rh protein as foreign, it remembers. In subsequent pregnancies with an Rh-positive fetus, the maternal immune system can respond more rapidly. Antibodies may cross the placenta and attach to fetal red blood cells. This can lead to their destruction before or after birth. The effects on the fetus vary in severity. Some cases involve mild anemia or jaundice that resolves with treatment. Others can progress to serious complications if left unrecognized. The risk is not constant and depends on timing, antibody levels, and medical monitoring. Importantly, this outcome is not inevitable. It reflects an unmanaged immune response, not a natural requirement. Outside of pregnancy, the same principles apply to blood transfusions. If Rh-negative individuals receive Rh-positive blood, sensitization can occur. The first exposure may not cause an immediate reaction. However, future transfusions become more complex and risky. This is why blood donation systems carefully track Rh status. The rarity of Rh-negative blood in some populations adds logistical pressure. Hospitals must maintain compatible supplies for emergencies. In trauma situations, decisions are made quickly, often before full testing is possible. Knowing which blood types can be safely used becomes critical. The Rh factor plays a quiet but decisive role in these moments. What makes this system challenging is its conditional nature. Most people never encounter a situation where Rh status matters. Yet, when it does matter, the consequences can escalate rapidly. This duality made it difficult to recognize historically. A factor that is silent most of the time leaves few clues behind. Modern screening transformed this uncertainty into predictability. Routine blood typing during pregnancy identifies potential incompatibilities early. Preventive measures can be applied before sensitization occurs. The biology did not change, but our ability to anticipate it did. This shift turned a hidden risk into a manageable one. The persistence of Rh-negative blood in human populations raises an important question. If incompatibility can cause serious complications, why did this trait not disappear over time? From an evolutionary perspective, traits usually remain because they carry some advantage or are linked to one. In this case, no single explanation has been confirmed. Researchers approach the question through hypotheses rather than conclusions. One possibility involves historical disease pressures. Some studies suggest that certain blood traits may influence susceptibility to specific infections. Under past environmental conditions, these differences could have offered subtle advantages. Any such benefit would have been context-dependent and geographically variable. What helped survival in one region may have been neutral elsewhere. Another factor is that Rh incompatibility rarely affects first pregnancies. For most of human history, many individuals had only one or two children. This limited the opportunity for sensitization to cause repeated harm. As a result, the selective pressure against Rh-negative blood would have been weak. A trait that rarely causes immediate failure can persist. There is also the role of genetic linkage. The Rh factor does not exist in isolation within the genome. It may be inherited alongside other traits that had stronger survival value. In such cases, selection does not act on one trait alone. It acts on the combined outcome of multiple inherited features. Balancing this persistence are the hidden costs. Before modern medicine, Rh incompatibility likely contributed to unexplained infant loss. These outcomes were often attributed to other causes or simply accepted as unavoidable. Without a visible pattern, the cost remained diffuse. The biological mechanism operated without recognition. Even today, risk reappears where monitoring is limited. In regions without routine prenatal care, sensitization may go undetected. Access to preventive treatment is not uniform globally. This creates unequal outcomes despite shared biology. The risk is not inherent to the blood itself, but to gaps in care. Blood donation systems also reflect these trade-offs. Rare blood types, including Rh-negative variants, require careful coordination. Maintaining supply is costly and logistically complex. When shortages occur, the consequences are immediate. This transforms a genetic detail into an infrastructure challenge. The Rh factor illustrates how evolutionary neutrality can coexist with modern risk. A trait that persisted without issue for centuries now demands management in complex medical systems. Biology does not adapt at the pace of society. Instead, medicine adapts to biology. Understanding this balance helps explain why some risks emerge only after progress. Today, the Rh factor is rarely discussed outside clinical settings, yet it is checked routinely. A small protein on red blood cells quietly shapes medical decisions in hospitals every day. Its management has become standardized, predictable, and largely invisible to patients. This is often taken as proof that the problem no longer exists. In reality, it means the system is working. Awareness remains essential because prevention depends on timing. Prenatal screening allows doctors to identify potential incompatibility early. Blood banks rely on accurate typing to avoid sensitization during transfusions. In emergencies, protocols are designed around these details to reduce risk. None of this functions without collective attention to a trait most people never feel. Responsibility in medicine does not mean assigning fault. Rh incompatibility is not a failure of the body, the pregnancy, or the individual. It is a natural variation interacting with immune memory. When complications occur, they reflect missed detection or limited access to care. Precision in language matters because misunderstanding can cause unnecessary fear. Preparedness extends beyond pregnancy. Donors with rare blood types play a critical role in medical systems. Their contributions can determine outcomes for patients they will never meet. This makes blood donation a form of shared biological responsibility. Infrastructure exists to manage scarcity, but it relies on participation. Understanding the Rh factor also reframes how we think about inherited traits. Not every difference is visible, and not every risk is constant. Some only emerge under specific conditions. Medicine's task is to anticipate those conditions, not to eliminate variation. This approach allows diversity to exist without turning it into danger. If you are comfortable sharing, consider leaving a comment with your blood type or an experience related to blood donation, pregnancy, or transfusion. These stories help document how these hidden systems intersect with real lives. They also guide which questions deserve deeper investigation next. Quiet details like this shape outcomes more often than we realize.